My dear students, our today's topic would be from surgery. I would be covering up pathological perspectives as well, and the focus of today's topic is the benign liver lesion, which we call as the adenoma, the hepatic adenoma. How this question has been asked in the previous exams, I give you a clinical scenario, say a 35-year-old female who is on oral contraceptives, presents in surgical OPD with acute abdominal pain. She progresses to shock. An immediate ultrasound shows a lesion in the liver, which is benign. The most likely diagnosis is. So we would be just coming to this question, and it will be clear to you in a short period of time what we mean. Now, as far as the hepatic adenoma is concerned, you have to remember that it is a benign proliferation of hepatocytes. It is a benign liver tumor, and it is more common in young females. Now, who predisposes to this condition usually? You have to remember certain associations. Number one is the presence of glycogen storage disease type 1, which we call as von Gierke's disease, and it is typically associated with the development of hepatic adenomas. Then we have this another defect which we call as galactosemia, and galactosemia has a significant association with the development of hepatic adenoma, in addition to a disease which we usually associate with the intake of anabolic steroids. Oral contraceptives, as I mentioned in the class and just few seconds back, already have an association with the development of hepatic adenoma. Then you have to remember these two additional drugs, the anabolic steroids, the clomiphene, as well as danazol. So remember the associations of hepatic adenoma. What predisposes to hepatic adenoma is glycogen storage disease type 1, galactosemia, oral contraceptives, as mentioned in the question, anabolic steroids, clomiphene, as well as danazol. This is a bit of a history which we usually give associated with the development of hepatic adenomas. Examiners love to give these associations. Now, how does it present? Usually, hepatic adenomas are not discovered and they remain asymptomatic in most of the cases, but they might bleed, and there can be accompanying hemorrhage and necrosis. And why do they bleed? They bleed or rupture into the peritoneum, and a patient can present in the form of an intraperitoneal bleed. Now, have they got any malignant potential? Very low. The malignant transformation of hepatic adenomas is low. Now, what is and how do we detect these masses? They can be detected incidentally. Patient comes with something else, and on an incidental finding, we find the presence of an hepatic adenoma. USG can localize those tumors. CT and MRI would be helpful, and CT and MRI can be superior as they can just show the lesion more visibly, and usually they will be appearing as well circumscribed lesions. The capsule will be very nicely seen, and they might be hypervascular, as well as heterogeneous masses on CT or MRI. Now you have to remember that we do not do core biopsy in case of adenomas, but angiography can be used, and angiography would again detect hypervascularity within the vessels. In addition, you have to remember that what is the mode of treatment of hepatic adenomas? Asymptomatic masses, you just don't deal, you just manage them conservatively, but in case they rupture or they present as an acute hemorrhage, hepatic artery ligation is done in these cases. Now, if these masses tend to be symptomatic, cause recurrent pain, and are greater than 6 centimeters in dia, then we do surgical excision of these masses. I hope that you just remember these points about hepatic adenoma. And in addition to that, you have to remember that you will not be having the typical things which are characteristic of hepatocellular carcinoma. They will not be, say, the markers, etc. They will not be elevated in case of hepatic adenoma. So this is what you should remember about hepatic adenoma and the associations and the presentation and the treatment part. Thanks a lot.